I'm going to grab that screen share. Thank you. All right. So today's talk, we're really kind of just focusing in on the most common dementia syndromes. And we'll kind of take a look at what might be a reason to refer to our memory clinic versus maybe the research side, just helping differentiate that given our wait time. So but I want to really first just kind of define neurodegenerative diseases so we're all on the same page with that. And then the most common question I get in the clinic, and this is partly because of our fault with terminology, is like, what's the difference between Alzheimer's disease and dementia? So I'll highlight that. But then we'll kind of look at two case examples too. So when we define these diseases, they're typically insidious onset, meaning it's not like a stroke where it happened yesterday at 3 p.m., right? This is something that comes on gradually, and oftentimes it's really unclear exactly when it started. To get the best history, you usually need to have some sort of caregiver or spouse. The patient is not going to be able to remember. And when they do, it's usually in the last year, things have gotten a lot worse, right? Where it's really interfered with a lot of things. I will say I ask about it every time, but to see if there is some sort of unmasking event, it's not uncommon that I'll hear that things seem different after that heart surgery, or things seem different after this delirium event of some sort of etiology, whether it be major illness or surgery. But then we're also looking for progressive decline. That is the definition of neurodegenerative diseases. These are things that get worse with time. And they do so because we get progressive loss of the brain synapses and the brain neurons. There's undergoing synaptic loss and death. The hallmarks of all these diseases are essentially misfolded proteins. At least that's what we see on pathology. So we see amyloid plaques, we see tau tangles. Those are both associated with Alzheimer's disease. We see alpha-synuclein clumps called Lewy bodies that are seen in Parkinson's disease and Lewy body disease. And then we see the newest kid on the block, TDP43, which contributes to a lot of frontotemporal disease disorders. And essentially, when these proteins start to clump up, one of the reasons that they're causing problems is they have a loss of function. There's a loss of the normal functioning proteins. These all have a role within our cells. So there's a loss of function that's occurring. But then there's also this theory that there's a gain of function, meaning if you've got an abnormal tau tangle, it can start to influence the next tau protein and cause some sort of gain of function problem. So I didn't really have a good spot in our Pocket Talk series to have this slide. And I think it's something that really we need to be thinking about moving forward. So this is not quite yet, but maybe some of you have run into this. There's going to be in the near future where someone comes into your clinic with just an abnormal amyloid blood test. And I will tell you, this amyloid blood test seems pretty good at detecting, being indicative of amyloid plaques in the brain. Maybe they've got a family history of AD. That's why they got this test. They were concerned. But they're currently unaware of any cognitive difficulties. And so do they have the question then that they ask you is, do I have Alzheimer's disease? And I'll tell you, that's a major point of contention in our field of whether this is a biologic diagnosis or a clinical diagnosis. Can you diagnose Alzheimer's disease without symptoms? We have plenty of other examples of patients being diagnosed with diabetes and hyperlipidemia with biomarkers, right? You don't need to have neuropathy for diabetes to be diagnosed. However, most of us, at least at this current time, until we can sort of more definitively prove things where we know the actual risks of being amyloid plaque positive, most of us still require some sort of clinical symptoms to make this diagnosis. But just be aware that this is something that we're all kind of grappling with, especially in the era of biomarkers that we have. I wanted to also have this slide because I don't want to point out that there's going to be no brain scan and no blood test that can make a diagnosis. I often get this question, well, can I just get a scan and you tell me if I have Alzheimer's disease? It's not that easy. You need a detailed history. Just like I told you, it has to be something that's getting progressively worse. Has to be some sort of history of this, right? You need to rule out other things with your physical exam. You need to do a mental status exam. Do they actually have cognitive impairment, at least on some sort of examination? You want to be ruling out, even if you are finding cognitive impairment, what if they have uncontrolled depression, their GDS is 13, right? That would be important to know. What if there's medication side effects? What if they're on acetylcholinesterase, or if they're on acetylcholine blocking medications, right? Do they have sleep apnea? These are all the things we talked about in the prior 2 lectures, right? Getting MRIs, and I really just wanted to reemphasize that these are complicated puzzles. So here's my kids putting together a 1,000-piece puzzle, right? It's not that complicated, but we do require at least a couple pieces to make sure that things are lining up with an accurate diagnosis. And so that's neurodegenerative diseases, and then sort of this idea of kind of the puzzles. But what is dementia, or how do we define that specifically? So it's a decline in at least 2 cognitive domains. When we do memory-based testing and language-based testing and things like that, we see a decline usually in 2 cognitive domains, and that's also enough to start to interfere with everyday function. So we all like to use this umbrella term, especially when I'm explaining it to patients. Dementia is an umbrella term, but it doesn't necessarily say why, right? The etiology, there's actually a number of different common etiologies even. If you like a table form of definition, I think this one's nice, of just kind of, are they having impairment in activities of daily living? That's really what we're defining dementia as, right? Compared to mild cognitive impairment. And so with these umbrella ideas, there are generally things in the history that can at least point you in the right direction. Number one, from a percentage standpoint of what you're going to see, especially out in not a specialized academic, memory clinic like me, most of what you're going to see is Alzheimer's disease. There's often going to be short-term memory issues, repeating questions, forgetting appointments. Where we start to think more about vascular disease, if they've got a history of lots of strokes, if there's a lot of white matter disease on the MRI, Lewy body disease. If you've got 2 out of 4 of these features, you don't have to have all 4. But if you've got somebody that's clearly acting out their dreams, they have REM sleep behavior disorder, and they have like cognitive fluctuations, they don't need to have visual hallucinations and Parkinsonism to meet this diagnosis. But that was something this is one that often gets missed. Frontotemporal disease is really where we're either looking at behavior changes when the right side of the brain's involved, or language symptoms if the left side is involved. We're going to have a talk on each one of these, so I'm not going to go into more detail there. As far as the percentages of just kind of what we usually quote, somewhere between 60 to 65% of dementia is due to Alzheimer's disease. And then if you lump Parkinson's disease and dementia with Lewy bodies, which is really the umbrella of Lewy body dementia, about 20%. So it's the second most common, and vascular dementia after that. Frontotemporal dementia is less common. And the reality, as we study more brains, under autopsy, especially for folks over age 75, is there's often an overlap of some of these, where we actually often see Alzheimer's disease and Lewy body disease in someone's brain. But we can generally determine which one was the primary one, and that's really what we're trying to do on the clinic side anyways. So to that question, kind of what's the difference between Alzheimer's disease and dementia, I always start with defining dementia as an umbrella term, just like we did. It's impacting daily function. There's multiple causes of dementia, Alzheimer's disease being the most common one. But Alzheimer's disease is really it's a neuropathologic diagnosis. It is, we don't make that diagnosis on an autopsy unless there's amyloid and tau proteins there, right? And now we have the ability to detect these things in life without brain tissue. So we can detect biomarkers of amyloid and tau, and that's something that we sometimes do even in our clinic now. It's also really pointing out that Alzheimer's disease is not just dementia, it is really a spectrum, right? So we talked about mild cognitive impairment in the last few weeks, and there's this idea of, could people be pre-symptomatic even? The more severe the pathology and damage in the brain, the more likely someone is to have dementia. But there is a slight caveat to that, meaning cognitive reserve building up your cognitive reserve can offset some of that pathology. Not everyone that has amyloid plaques and tau tangles in their brain has Alzheimer's disease dementia. So biomarker stages, I'm not going to go over this in too much detail, but I just wanted to highlight that this is where we're kind of thinking that, yeah, if you've got amyloid changes occurring 5 to 20 years even before symptoms, before this mild cognitive impairment stage, then probably at risk would be the most accurate way to determine or to define that, right? Even if you don't, I don't think it's accurate to call it Alzheimer's disease with how loaded the term is, but at risk, right, would be reasonable. It's once the tau proteins start to change is when we start to see the cognitive symptoms develop. And then when we're seeing atrophy on the MRI, that's usually when we're starting to get more closer to the dementia stage, where these cognitive measures or it's really the daily function changes that we see, obviously defining this stage. It kind of highlights also where we struggle if we're utilizing cognitive measures and ADL function as our outcomes. We're missing a large window of this disease and impact, right? And so that's that's some of the difficulties in Alzheimer's research right now. So to our patient earlier, the better question, right, is, am I at risk for this? And I like to use the analogy a little bit like just thinking about this from another disease standpoint in ways that can make sense is, if you're amyloid positive, that might be more akin to a pre-diabetic state, right? You're not guaranteed to get it. Whereas so like if you're amyloid positive for 20 years and then you die of something else, right? Obviously you never developed Alzheimer's disease dementia, especially if you're amyloid positive at age 80, right? But if you've got amyloid positivity and tau positivity, that's kind of the definition of Alzheimer's disease. That's more like having diabetes, but maybe it's a hemoglobin A1C of 7, right? Whereas if you've got kind of those biomarkers, plus you've got clear brain shrinkage, the MRI is showing damage, then that's really closer to uncontrolled diabetes, and that's where bad outcomes are near, right? This is really a more probably accurate way to think about how to apply these biomarkers. But again, the field is, the Alzheimer's field is, there's different opinions on that, and I think there's going to be back and forth with that. So let's do just 2 brief clinical puzzles. So this first one is 72. Her husband passed away 4 years ago. It was a very stressful event. She started to have difficulties finding words, but it was kind of in the context of all this other stuff going on, trying to plan the funeral and not losing their partner and having to start to take over some of the daily activities that she wasn't used to doing. And so very reasonable to say that this seems more like all the stressors going on, right? But over the last year, she's had more significant decline, getting words out in conversation. She's losing her train of thought easily. She's struggling with multi-step commands, and there's significant anxiety associated with the symptoms. So it kind of forms this worry loop that we often see in patients. And there's no major concerns with her short-term memory at this point, but she is starting to have some difficulties with daily tasks, including missing medications, organizing her finances, and kind of step-by-step things like cooking meals. And so obviously this is a very short narrative version of her full history, but what we can start to think about is, is she having a behavioral symptoms? Not necessarily. We said she's not really having major short-term memory issues. It doesn't seem to be a visual spatial issue. She's describing language problems and then sort of executive function issues if we're thinking about troubles with cooking, sequential task type of things, organizing. So the initial workup with folks that are presenting with cognitive issues, right? We've already talked about these, but working on those reversible causes, going over medications, make sure there's not any of these medications on board. A sleep study showed moderate sleep apnea, so we recommend CPAP treatment for that. Hearing tests, anytime someone's having language issues, we want to make sure there's not hearing issues going on, and those were normal. A screening tool with a good test like a MoCA was done, and this patient scored 19 out of 30. They're missing points on the language portion of the testing, as well as visual spatial, just a little bit more than memory. And specifically really struggled to repeat a complex sentence. And so that was one of the issues that she was having within that language domain. Her MRI scan, basically, why do we do this? We kind of pointed out in the last talk, but we want to rule out structural problems. Most radiologists don't use quantitative programs, so they're not going to pick up on subtle asymmetries. They're really just looking for large changes, right? When we're talking about neurodegenerative diseases, most of the reads are going to look like this: generalized atrophy without specific pattern. And then almost everyone over age 65 has some amount of chronic ischemic small vessel disease. So you're going to see that in almost every report. If you do refer a patient to us, we don't want to just see the report. We actually want to see the actual images. So any way you can help facilitate that is ideal. When I looked at her MRI, these things are super subtle, but if this is the front of the brain here, the back of the brain here, there's just a little bit more cortical loss along the left hemisphere compared to the right. A little bit more spinal fluid, which is in black here compared to the right. She's also just slightly tilted in the scanner, but overall, and then we look at the parietal lobe, there's just a little bit more atrophy on the left than the right. So these are clues to me that something might be going on in the left side of the brain. And I'm already thinking that with the history because she's got language predominant symptoms, right? So this is just another clue for me that maybe we were dealing with something more language based. And so like with this patient, they've got this history of a progressive neurologic problem. It seems to be neurodegenerative. We're thinking maybe a primary language disorder based on the history and the exam. Her cognitive testing seems to be more of a non-amnestic type with language, but her MRI wasn't really helpful in this scenario, at least not from kind of the baseline read and things. It was non-diagnostic. This would be a very reasonable patient to refer to us because this is more of a specialized academic center case, right? And this is a case where we would probably pursue an FDG PET scan for a more definitive diagnosis. Because we have a long wait time, right? We have to prioritize our referrals, and it'd be very reasonable in this case. There's been a screening test done. It's abnormal. The current diagnosis is uncertain. We're seeking a diagnosis. Reversible causes, MRI have been performed. We see lots of referrals for family history of AD or memory concerns without any real history taken. AD dementia, seeking new drug trials. We have lots of ways to connect with those patients, especially on the research side. And that's a totally different referral. So the research team can handle those things. And we've got plenty of studies for folks that have either normal cognition or mild cognitive impairment or dementia. But in some cases, it really does help to have that testing done so our team can triage those referrals. And that can also help us if we're trying to, battle, where we're getting way more referrals than we can see. The more information we have, the better. In this case, so detailed neuropsych testing was done as part of our intake visit in the memory clinic. And our neuropsychologist noted that there seemed to be more prominent deficits in language and executive function. This is a multi-domain impairment. And since she has decline in daily functioning, that's consistent with mild dementia, and it's more in this non-amnestic pattern. And they had noted that, with the language involvement, maybe this is more of a dominant hemisphere, or most of the time that's the left hemisphere of the brain. But with language, we know that frontotemporal disease and Alzheimer's disease are kind of the two big major causes of language disorders that are progressive. When we think of the brain like in a whole, right, we think of like the back part of the brain being visual spatial, the front being more behavioral, executive function. And this temporal lobe is really a better part of the brain for language processing. And so that's where we're thinking of. And I kind of pointed out a few of those changes on the MRI that were more subtle, but it really does probably require a more detailed test here. And in this case, this is where the role of the FDG PET scan comes into play. This is something that probably should be ordered mostly at an academic center at this point. But it allows us to really see how is the brain working rather than just what does it look like, right? It's also a very useful tool for patients that can't get an MRI. Maybe they've got claustrophobia or a pacemaker or a neurostimulator. or when the MRI has been non-diagnostic. But we're able to see patterns of brain network failure on these scans, and it really does help us. It is approved. It's been approved since 2006 for FTD versus AD, which is exactly what we're using it for in our case. But I will tell you, the reads of these are not always highly accurate. I have to basically read my own scans with these. So that's why it should be probably more specialized. But I think what's really going to change with that, just to give you a heads up, is once AI, I mean, these are all pattern recognition. AI is going to solve this issue. Mayo's already working on a pretty good program that can put people into the correct clinical boxes based on AI programs. So that'll change in the future. But as of right now, the way we look at these scans on Cortex ID can really help us recognize these patterns. And so in this scan, gray is all normal. And this is basically measuring how are they metabolizing glucose or using energy. And on the right side of the brain, it looks pretty darn normal. There's some subtle patchy changes, but the more abnormal things are along this bar, you know, red being more severe, you can see that on the left side of the brain. This is exactly what we would have thought was going on as far as this left temporal lobe and the left parietal lobe is where we see a lot of changes here. And this is highly consistent with the pattern that we see in logopenic primary progressive aphasia, which we'll have a talk on that later. And I will tell you that most of those cases, 90% to 95% of cases are due to Alzheimer's disease proteins, that amyloid and tau protein. And so, you know, we could do something called Alzheimer's disease biomarkers in this individual to be more certain about that. That's something that we can do in the spinal fluid. And this individual, you know, positive for amyloid and tau changes. So we know pretty definitively that this individual's problems are due to Alzheimer's disease, which opens up windows for research referrals for Alzheimer's studies, right? When we start to have these different medications that are targeting Alzheimer's proteins, having this more definitive biomarker proven diagnosis is going to be where we're moving. All right, so let me contrast that case real quick with a separate case. So this is going to be more commonly what you're going to see. That was a pretty highly specialized case right there, pretty atypical. So a 76-year-old that presents with 4 years of memory concerns, the repeating questions, missing appointments. They missed a couple of the primary care appointments. They're living at home, maintaining most ADLs, but starting to get difficulties with paying bills and missing medications. Navigational problems are arising. On a Montreal Cognitive Assessment, they score on a mild dementia range, but they're missing basically all their points on delayed recall. So it looks pretty amnestic and starting to involve maybe the executive function domain too. And so like on an MRI scan here, this is the top of the head up here with the two halves of the brain. We see a lot of central atrophy occurring, but where we're seeing the majority of the changes is in these memory structures, these hippocampus structures right here. And if we remember from the previous talk, we can kind of utilize this imaging scale, right? And they basically match up with this MTA equals 4. It really fits, right, with the overall clinical picture of a memory problem. And that is the area that Alzheimer's disease tends to target in these amnestic disorders. So like in this scenario, right, we've got all these puzzle pieces basically matching up. And I wouldn't get a PET scan in this case, right? I don't even think we need biomarkers unless you're thinking of basically, you know, doing some sort of anti-amyloid therapy in the future or some other, you know, biomarker targeting test. This would be a great research referral, right? Getting them plugged in with a proper social worker for caregiver support and resources. But this wouldn't be someone that necessarily needs to be referred to a specialized clinic. And so the future tools, I alluded to this earlier, but I guarantee you AI will really help with this FDG PET scan issue of poor reads, and we're gonna really be able to utilize this in the next couple of years. We do have biomarkers available to us right now as far as spinal fluid markers, but these blood-based ones are coming, and you're going to see more and more tests. We're going to be testing it in our clinic soon as well. We already use these on the research side. We even use them to help with enrollment in our research studies already. So they're being used. They're just not quite ready for prime time in a primary care clinic. There's a couple things we need to hammer out. And then we're regularly using skin biopsies to help with Parkinson's and Lewy body disease diagnosis. We can detect these proteins in the skin. There's more affordable genetic testing available now. We utilize Invitae's testing panels. And then we've also got more specific amyloid and tau PET scanning, which are FDA approved, but no one's covering them yet. So I think these are going to be more important once we are able to utilize these disease-modifying therapies, though. And just to highlight, so if we think of Alzheimer's disease as a spectrum of different diseases, this is a PET scan versus a tau PET scan, and the tau really tells you where the problems are in the brain. These are all Alzheimer's cases. This one looks a lot like that case I just showed you, right? This is a logopenic, more of a language-based case. Here's more of a typical memory disorder case. And this is a visual spatial where the back of the brain is really involved versus this would be like a 56-year-old young onset dysexecutive case. And so these are all due to Alzheimer's disease, but we can clearly see that they present differently when we can really look at how is the brain working and then where's that tau. All right, so I'm going to go ahead and pause there. I see there's lots of things happening in the chat, so I want to check on that. But let me stop sharing real quick while you guys pull up your slides. All right, so some of these are CE stuff, so thank you, Paul, for getting that out. Yeah, so a great question. So what is a typical presentation of AD? That's a great question because, yeah, well, so the textbook typical presentation is short-term memory predominant problems, right? So that is basically the majority of what we see in folks over age 70. You know, it's going to present as a short-term memory problem. For me, typical AD is very broad because I see a lot of atypical cases, and I, you know, it's probably somewhere around 65% are that typical presentation. But there's plenty of atypical ones too. Do I order an MRI if the history is consistent with AD? You know, it is a little bit dependent. I think if you've got somebody that's like, there's been very clear 5-year history, the cognitive testing's consistent, the B12 has been checked, there's really no other concerns of something else. I think it's reasonable, but I say that with one caution is because I've seen cases that somebody actually had a stroke within the anterior thalamus, you know, of the memory circuit, right? And so their short-term memory issues were actually due to a small stroke and it was not due to AD. So I would really not want that person enrolled in an AD study, right? So I still think an MRI has a role even when you're pretty sure it's AD, but I would say those are more rare cases, obviously. Yeah, so Robert, you asked a good question about the skin biopsy versus DAT scan. So I personally use the skin biopsy over DAT scan. I have a couple reasons why I order a DAT scan, but I rarely order them. The skin biopsy is more sensitive for earlier symptoms. So if I'm a little less certain, there's just subtle Parkinsonism and I'm, you know, maybe they've got constipation, lack of sense of smell, they've got orthostatic lightheadedness, they've got REM sleep behavior disorder. So I'm leaning towards a synucleinopathy like Parkinson's, but their exam is, you know, maybe an essential tremor or just very subtle rigidity. There's a chance on a DAT scan that's going to look more normal than not, unless symptoms are more obvious. And then when I'm kind of in a position where symptoms are more obvious, they've got a unilateral tremor, they've got rigidity, they've got shuffling of gait. Like I don't need a DAT scan at that point either. So that's usually why I rely on a skin biopsy. But I have used a DAT scan in cases. So one specific scenario where I found it very helpful is somebody that's on. Maybe they've got a history of psychiatric disease. They're on dopamine blocking drugs, right? Is this drug-induced Parkinsonism versus an early unmasking of Parkinson's disease? A DAT scan will help you there because it's normal in the drug-induced Parkinsonism. But that's really the only scenarios I use that right now. But excellent question. You certainly could use a DAT scan if that's something that you're used to using, but it's not quite as sensitive, especially in the MCI stages of these things. All right, any other questions? I think somebody was unmuting themselves for a little bit. I don't know if they're still on. All right, and I think, yeah, our May 19th one. So this is going to be a new one this year. I still got to put some stuff together for this, but I wanted to have a talk on delirium just because I feel it's something that can be preventable. There's at least things we can do to lower the chances of it happening. And, you know, I think that it's a major risk factor for progression of these neurodegenerative diseases, or at least unmasking them. So I do want to talk about that. One more question on the blood biomarker. So yeah, the Quest biomarker, do you know, is it through, so I know about the test. I know it's going to measure amyloid. Do you know which tau measure they use on that one? Yeah, it's only amyloid. Yep. So that's similar to what, so C2N Diagnostics is a company run through Wash U, and so they have a similar where it's mostly just an amyloid test, which is why I brought up that case at the beginning, right? There's people that are going to find out they're likely amyloid positive, but it's you know, unclear exactly what that means as far as their exact risk, right? I will tell you, I'm not too excited about just seeing an amyloid test. I haven't ever ordered it, and the reason being is because I know that 60+% of Lewy body patients are amyloid positive. So I definitely don't want that to be for me to not ask about, you know, Lewy body disease if I'm thinking, oh, this is Alzheimer's disease because of a blood biomarker that says amyloid's there. We know that there are Alzheimer's disease mimickers in patients 80, 85 and older, where they can be amyloid positive, but it's actually this TDP-43 late disease. It's not actually tau that's causing the damage. And so until we can like definitively have a tau blood biomarker, which there is a tau P217 that looks a little more promising, yeah, I don't see myself ordering the blood tests, just for mainly for that reason. Yeah, so Heather asked, good question of, can you order the skin biopsies as an outpatient? So you absolutely can. You do, so like we do them in our clinic right now, Heather. We don't do that many of them, but a couple times a month we do them. You do want to like connect with the company. You want to like have them come out and train you and things like that. There's not many places I know of that's doing them though, like regularly. So, you know, our clinic already is at capacity for our biopsies, but I know like there's some places where like dermatologists are doing them. I mean, you could certainly partner with someone that can do skin biopsies, and then it's really just all it is 3 punch biopsies. They don't even need a stitch. They just basically you know, a glue healing it. So it's a punch biopsy in the cervical neck, the thigh, and the leg, and then you send it off, and the pathologist will read it, looking for that misfolded synuclein protein. But yeah, and I guess one of the questions there too is, can you order it? Yes. You obviously have to have someone that's going to do it. But then insurance covers it in many of our cases. So it is an insurance approved test as well. All right, we're a few minutes over. Excellent questions. We'll be back, so 2 weeks with delirium. All right, thank you all.